Well, thank you very much. I really didn't catch that this was a debate when I was given this topic. And I actually don't think there is much of a debate, and I probably got the easiest assignment anyhow. So let me go on. That was spirited presentation by Kenny, but I'm not really too concerned. So these are my disclosures. I do want to point out that I have done some work with Silk Road, and that while I'm a surgeon and I do endarterectomy, I do also do transfemoral carotid stenting as well as TCAR. But my assignment's pretty easy, and this is it right here. I mean, carotid endarterectomy clearly remains the gold standard. It has been proven to be safe and effective treatment for prevention of strokes in patients with carotid stenosis. There is more level 1 evidence that's been created with carotid endarterectomy over a longer period of time than for any other surgical procedure done in any surgical field. And that level 1 evidence supports its effectiveness in treatment of both symptomatic and asymptomatic carotid stenosis. So I rest my case. So some of that data is here. People are familiar with this. Some of this is dated, but there's no question that in the head-to-head randomized controlled trials against best medical therapy at the time, that there was unequivocal benefit of CEA in patients with asymptomatic carotid artery stenosis exceeding 60%. The same has been true with even greater effectiveness in the treatment of symptomatic carotid stenosis, greater than 70%, with really significant absolute risk reductions demonstrated in those trials. The problem is that all the cardiologists and other specialists would have you think that this is what carotid endarterectomy is like. The fact of the matter is that this is an incredibly well-tolerated and reproducible operation. More than 85% of the patients go home after a one-night hospital stay, no different than carotid stenting. The recovery is actually quite short, even though people would try to tell you that there's some crazy incision that we make. And there's an actual relatively low risk of major or any permanent complications associated with this procedure. Well, what about carotid artery stenting? Is this really the new way for us to go? It's not that new, actually. I've been involved in carotid stenting for years and years. But the problem, especially as surgeons, that we have with this procedure is that we actually see what this stuff looks like, right? You open the carotid artery and you see just this mush. And you just think that whatever I do, if I balloon this, stent it, tickle it with a wire, what the hell is going to happen to all that stuff? We should just be, clamping the vessel, opening it up, cutting this stuff out, and that's the safest way to take care of procedures. Well, a whole host of embolic protection devices and new devices and stents and whatnot are being developed, and yes, they are improving the effectiveness and they can capture some debris, but it's not 100% effective and nowhere near the effectiveness of doing it surgically and just removing that plaque itself. When we look at transfemoral carotid artery stenting, there's additional risks beyond just ballooning and instrumenting the lesion. It's crossing the arch, crossing the lesion before you've established protection. Certainly in many of the studies that have been done head-to-head, there's nearly double the stroke risk that's been shown with carotid stenting versus surgical endarterectomy in virtually every trial. If you look at some meta-analyses and pooled analysis, this is a pooled analysis looking at NACIT ECST data, also head-to-head endarterectomy versus stenting trials, EVA3S, SPACE, ICSS, CREST. If you're looking at stroke and death rates, which I would argue are probably more important than the overall composite endpoint that also includes MI and other things that's been used to show that carotid stenting might be close to endarterectomy, but it's not really. CEA clearly has the lowest early event rates when we look at stroke and death. CAS has higher event rates than CEA. That's, I think, been pretty clearly been shown. And especially if you look in symptomatic patients who are treated really early on, endarterectomy really wins, and the events are even higher in carotid artery stenting. I think there are some caveats with all this data, of course, so some of these are older CAS trials, and there's newer data that's been coming out that Kenny and Ravi have shared with you as well. A lot of this data was created with distal filter embolic protection devices, and proximal protection may be better. Stent design could be criticized. A lot of these were done with open cell stent designs, and a lot of the periprocedural medical therapy with the DAPT treatment was being defined at the time and was somewhat unknown early on. And we do know that when we look at certain other complications, that MI and cranial nerve injury, certainly it's going to be higher with endarterectomy. This was pointed out as well, I think, by Peter specifically. Age matters for carotid stenting, but not for CEA. So if you look at the pooled analyses, including all those trials in CREST, there's no question that in patients beyond age 70, the event rates are higher, and they're not necessarily so with carotid endarterectomy. So CEA is superior to CAS for patients age 70 or greater, and age has minimal effect on outcomes after with CEA. There's some recent publications that have come out. The Cochrane group did a recent analysis analyzing endarterectomy versus transfemoral carotid artery stenting, and they reported that CAS for symptomatic carotid stenosis is associated with a higher risk of periprocedural stroke or death than CEA. And also breaking it down in those age groups as well, that still stands with additional new data. If you look for asymptomatic carotid stenosis, there may be a small increase in the risk of stroke or death with CAS. It's less clear, but it still tends to favor endarterectomy. That being said, if you take out major strokes, or take out the major strokes or minor strokes, which is really what you see mostly with carotid artery stenting, that difference is less significant. Some people say, well, there's newer data that's coming out, right? More recent, right? ACST2 that came out recently, I think in the last year or so. So this was an updated meta-analysis now where they dump that into there as well. It still doesn't change anything, right? So if you look at any stroke or death or any stroke, still clearly favors CEA in this meta-analysis. Definitely when you look specifically at MI, that favors CAS. It is a little less clear, especially for asymptomatics, when you start looking at major disabling strokes and death and disabling stroke. There it's a little bit more of a wash. Kenny showed this slide. Everybody likes to say, well, CAS is new, it's getting better and better. Forget the old results, the new results are great. There's been improvements in technique, in embolic protection, and patient selection for carotid stenting, and we can get better and better. And yeah, that's true. So this is the same paper that Kenny just showed, right? So it has improved. If you look at some of this, it's not necessarily transfemoral carotid stenting, and it may actually be TCAR to support Brian a little bit. I know they got beat up in that last talk. So a number of these studies with the more favorable results that have come out recently and shown how much better carotid stenting is getting are actually from flow reversal or flow cessation or TCAR type stuff that's in there. But the same is also true for CEA. We've gotten better and better, and I think that has to do with better anesthetic and medical management in addition to CEA, that when combined, that the results continue to get better and better. We know that CAS is going to continue to improve, I'll grant that, with different proximal protection techniques, TCAR, things like that, newer stent technology to prevent plaque prolapse after the fact. We know that if we look what's happening, that yeah, TCAR is a major player and that the rates of TCAR utilization have gone up dramatically, but CEA still tends to be the most prevalently performed procedure and the winner, of course, right? So is TCAR, let me pick on TCAR just a little bit, even though I am somewhat of a TCAR enthusiast. Is it really a paradigm shift? I'm not sure it's a paradigm shift. It's a new procedure, but in reality, it's just a combination of two things. We're doing a cut down and we're putting in a carotid stent still. So it's not really all that different, right? We're just mashing some things together there and saying it's better that way. TCAR definitely offers similar benefits as CEA, but with fewer adverse events and an overall simpler treatment, I think, than doing endarterectomy. It's definitely simpler to teach somebody how to do TCAR than to do a really good endarterectomy. But as Kenny pointed out, there are no head-to-head trials comparing TCAR to CAS or CEA or anything else. TCAR is not a replacement for CEA, but it definitely is complementary, and certainly I think there is some benefit in patients with difficult anatomy for CEA and high-risk patients. This is a little bit self-serving. This is the new guidelines that came out from the Society of Vascular Surgery, but they definitely prove my point, so I had to include them. Looking at asymptomatic disease, they say that CEA with best medical therapy is the best therapy, period. Drop the mic, nothing else. No discussion of CAS or TCAR as alternatives. They also recommend CEA over transfemoral carotid stenting in low and standard risk patients with greater than 50% symptomatic carotid artery stenosis. And that in particular has a grade 1 quality of evidence A recommendation. I do think it is important to think that some of these therapies are complementary, and I'll grant you that, and that's how I use it in my practice. There certainly are patients that are going to be at high risk for endarterectomy or high risk for carotid artery stenting, and we should factor that in. And when we're treating our patients, it's not a clinical trial. It's actually individualizing therapy to those patients, and that's how we should always practice. So I think in conclusion, there's no question that carotid artery stenting remains the gold standard for the treatment of symptomatic carotid stenosis over 50% and asymptomatic stenosis over 70%, and no other therapy by itself, whether it's best medical therapy, CAS, or TCAR, has ever been shown in any trial to be superior to carotid artery endarterectomy. Volume and outcomes and patient selection matter for everything, both for CEA and for CAS or TCAR. In any individual patient, the relative risks and benefits of these different therapies have to be considered, and there probably is a role for all of them, but I don't think that any therapy has supplanted endarterectomy for being the gold standard to which we compare everything to. Thank you.